So good morning, Dr. Fazel. We're excited about you joining us and talking about your manuscript that we have chosen as one of the editor's choices. It was on Determinants of Fluoroscopy Time for Invasive Coronary Angiography and Percutaneous Coronary Interventions. And it was insights from the NCDR, the National Cardiovascular Data Registry. I want to congratulate you on having looked at this.
Thank you, and I'd just like to take this opportunity to thank. This was truly a sort of a team project, and wanted to thank all the NCDR staff and my co-authors on the project, in particular, Dr. Nala Muther, Dr. Curtis, Dr. Krumholtz, and our statistician Yongfei Wang. And we had a big group, but this was truly sort of a team effort.
What we'd like to do today is spend a little time learning from you about what you found out from this very large database. And hopefully you can share with us some ideas about how we could take this information and implement that in our everyday practice.
So as you mentioned, this is a study looking at distributions of fluoroscopy time. And what we did was we used data from the CCI registry, which is part of the NCDR database. And it's a repository of data for all caths and PCIs performed at participating hospitals, which currently is about around 1,000 hospitals in the U.S. And we defined kind of different categories of invasive coronary angiography with or without bypass graft, and patients with or without bypass grafts, and PCI with invasive coronary angiography, and in order to be kind of comparing apples with apples, and basically looked at the distribution of fluoroscopy time for these different procedures, and also looked at the contribution of patient, procedure, operator, and hospital-related factors to the fluoroscopy time for these procedures. And part of the goal with this is there's been increasing attention to the issue of radiation exposure from medical imaging, and I think this is a lot more visible in imaging for CT and nuclear imaging, and our goal was to kind of look at this issue in cardiac fluoroscopic procedures. And the starting point, I think, for doing any sort of quality metrics in this regard is to find out what the sort of average what the distributions across the country are, to be able to have some kind of benchmarks. And prior to this study, there was very little data in that regard, and that was one of the key motivations for the study.
Well, I think it's great that you actually had a chance to look at such a large number of patients, literally millions from so many centers. One of the real points that people raise, of course, is the location of access. There's been a big dialogue now that the radialist rise has occurred. And perhaps you could share a little bit about what you found that occurred between radial access and femoral access with regards to fluoroscopy.
So the data we used within the CCI registry was from 2005 through 2009. And I think in the U.S. we're lagging a little bit behind Europe in terms of adoption of radial access, and I think that's reflected in this data that about 2% of the procedures for both coronary angiography and PCIs were non-femoral, meaning usually radial and in some cases brachial access. And in both of those cases, they were both for angiography and for PCI were associated with increases in fluoroscopy time. And I think, again, this the small proportion of cases that were performed through radial brachial access indicates this is kind of showing the early experience, and this may be sort of the early part of the learning curve where procedure access may take a little bit longer. And I think it would be interesting to look at this with more recent data, and I would expect that association with fluoroscopy time to increase fluoroscopy time to decrease over time with increasing experience with radial access.
Well, I think you're exactly right about that. We've seen that certainly from our European colleagues and our Canadian colleagues. But as you point out, this would be a great opportunity now to continue the dialogue about this and go back with a good baseline and look at what that transition means in terms of our practice patterns. If you're planning a procedure from this, you were able to identify those patient characteristics, hospital characteristics that seem to indicate you were more likely to have a longer fluoroscopy time. What were those, and how could those be modified to try to diminish the fluoroscopy?
Well, I think, we kind of looked at the patient characteristics and the procedural characteristics are typically things that we don't have a lot of control over. So, the patient's age or the complexity of their lesions. And this was actually one of the goals of the study, was to figure out how much of the variation in fluoroscopy time could be attributed to these kind of fixed factors where the operator really doesn't have, again, control over modifying those factors versus modifiable factors. And we used a hierarchical model to be able to tease that out. And based on our models, about 80% of the variation in fluoroscopy time was related to these fixed variables, and about 20% were things that we think are potentially modifiable and could be targets for quality improvement interventions. Things such as operator volume and things like that, and hospital characteristics.
So let's talk about the hospital characteristics. Are there things from a system standpoint that seem to improve that?
We did see some regional variation with some census regions having sort of on average higher fluoroscopy times. And in terms of hospital characteristics, one thing that kind of stood out was university hospitals, both for angiography and PCI, were associated with longer fluoroscopy times for these procedures. And I think and this is sort of more postulation on or speculation on our part, but we believe that's probably related to having trainees involved in the cases. And this association with longer fluoroscopy times with trainees involved in procedures has been shown in other types of fluoroscopic procedures like ERCP. So I think that is, obviously training fellows is necessary, and this is probably one of the trade-offs that we have, is a little bit longer fluoroscopy time.
Well, certainly that goes along as well with the experience level of operators. So the least experienced, of course, are going to be those that are first learning, and those, as we get more experience, increases. We always look for metrics of quality within operators as well. You use this as one of those objective parameters. Are there, cut points, or if you've done 1,000 cases, is that the point that you seem to be able to do this better? Is it 500?
So we did look at the relationship between operator volume and fluoroscopy time for both coronary angiography and PCI, and we saw a pretty smooth curve. There was a significant association both for angiography and PCI with fluoroscopy time and operator volume, and in terms of quantifying that for coronary angiography, with every increase, about 250 cases increase per year in operator volume, there was a decrement of about half a minute in fluoroscopy time on average. And for PCI, that was about 1.5 minute decrement per 250 cases per year. So we didn't, based on that analysis, there was no clear kind of inflection point to suggest that there's like a critical volume. It was more of it was a sort of a steady relationship along the entire spectrum. So I think the bottom line is the more experienced the operator, the lower the fluoroscopy time, and that association is along the entire spectrum.
So NCDR doesn't really provide you with a experience quotient or time in the saddle, if you will, how long you've been doing this. Were you able to get any information about post-training years of practice that might also look at this? That is, are you better or worse the longer you've been doing it?
That's actually a great question, and we really wanted to look into that, but unfortunately we didn't have access to more detailed physician characteristics, the AMA physician database, so we weren't able to look into that.
Well, this might be something that the SCAI might be able to help you with, and would be another one of those continuations. Any good research project is simply the start of the journey. I think the questions you've asked have been important for giving us a look at where we're at today. As you point out, though, we need to take this information, begin to look at what it tells us, and then move forward with how it can change our practices.
Exactly. And I think, one of the, if I wanted to kind of summarize the key takeaway point from the project, I think the key issue is just raising awareness of this issue. This is not the single most important thing, obviously, in the procedure, but just as, every operator during the procedure, they're mentally kind of keeping track of how much sedation the patient is getting, and how much contrast they're getting. This is very similar to those. Another factor that should be on the operator's radar. And I think traditionally this hasn't been very much a focus of, with our fellows, bringing this issue up in the past has not been a big part of our educational curriculum. I think that's something that can change. And again, I think it's just one of those things that, during the procedure, it's good to just mentally keep track of what the fluoroscopy time is. And since I think in 2006, the FDA has mandated manufacturers to include the key parameters for radiation exposure from fluoroscopy on the monitor. So it's something that's very easily trackable as long as we know what to look for. There are two parameters: the dose area product, or that's also called the air kerma area product, which is a reflection of the overall radiation exposure and the risk related. It's proportional to the risk related to the procedure, and the other is the air kerma at the reference point, which is a reflection of the peak skin dose. And I think that's particularly important now that we're getting into sort of with the technology available now. We have longer fluoroscopy times, like with CTO procedures. It's important to keep in mind, how much the patient's getting, and using techniques such as moving the camera around and avoiding steep angulations, and when possible to try to minimize the risk of skin injury with patients, in addition to reducing the overall cancer risk.
Dr. Fazel, I'd like to thank you for the work that you did along with the group. I think it gives us some great information about where we're at today. More importantly, some great ideas for how we can move forward and answer some of these questions in the future.
Great. Well, thank you again for having me and for the opportunity to talk about the paper.
Wonderful, and your team did a great job. Thank you again for spending a few minutes with us this morning.